Good afternoon, y'all. Did you say y'all?
Do we distribute leave you to it so we can see?
I hope you're having fun. I know we are.
We're getting off. Yes.
Did I do something bad?
Dr. Mark Fraser's program tells us that he has won numerous teaching awards. But I didn't know that when he spoke at the full semester seminar-style class that Joanne and Marshall and I taught on EBL. Perhaps it was a function of the environment. Perhaps it was just a case of being in the right time and place. Perhaps it was having the right people together, as I feel we do here. But to me, he did what teachers are meant to do. He brought new knowledge. He sparked ideas in all the class participants, including the instructors. And he asked, as we do here, questions of the type that challenge paradigms. You know, when I asked Mark Fraser to be a keynote speaker here, he asked me in our lengthy email correspondence why I'm not a librarian, he says. So in partial answer to that question, I'd like to share some quotes from a chapter that he wrote entitled Intervention Research in Social Work, a Basis for Evidence-Based Practice and Practice Guidelines. Just sort of a compendium of quotes. Dr. Fraser writes, fewer than 1% of the practice decisions made by social workers are influenced by research findings. Dr. Fraser writes, recognizing that the research bases of social work are interdisciplinary, one might ask, does the profession have a body of knowledge that can contribute to practice guidelines? In spite of advances, it is not clear whether social work researchers are producing new research knowledge. And finally, Dr. Fraser writes, the capacity of social work research to inform the development of practice guidelines rests not just with increasing the number of studies to test interventions, but also with increasing the sensitivity of research to the day-to-day practice. Sounds a little bit familiar. Perhaps you begin to understand why we felt he would be an excellent keynote speaker. So as you consider this very different model evolved for evidence-based social work, perhaps you will do as I had done, as our students had done, come away with your head filled with questions and ideas, and even new ways to think about what we've got as a model, what else might work. Please welcome Dr. Mark Fraser, the Dean for Research and the John A. Tate Professor for Children in Need at the UNC Chapel Hill School of Social Work, as he talks about evidence-based practice in social work.
Thanks, Carol. I'm terrified. I've never spoken to a group of people who come from information and library sciences. I was raised by librarians. I've lost thousands of Scrabble games. I know that your practice is far more complicated and increasingly science-based than the way an average person might think about a librarian who runs a public library. The same is true in social work, where people might think of a social worker as a caseworker who investigates a case of child maltreatment, or a probation officer who is following a juvenile offender and attempting to keep track of him or her as he or she walks the streets. So there are some similarities, I think, between your profession and mine, in that we have a large practice base, we have enormous challenges that confront us, and we are increasingly turning to systematic data collection, both qualitative and quantitative, to inform what we do. Let me start by saying a little bit about social work. Social workers help people overcome some of life's most difficult challenges, including poverty, discrimination, abuse, addiction, physical illness, divorce, different kinds of loss, unemployment, a variety of educational problems, disabilities, and mental illness. They help prevent crises and work with individuals, families, and communities to cope more effectively with all kinds of stresses. Social workers work in schools, hospitals, mental health clinics, senior centers. Some are elected to offices, some work in elective offices. Many have private practices, some work in prisons, in the military, in corporations, in employee assistance programs, in a variety of public and private agencies and churches, things like the Boys and Girls Clubs. There are 3 levels of social work education. A bachelor's level, about a third of social workers have a bachelor's degree in social work, and the remaining 2/3 have bachelor's degrees in all kinds of things: psychology, sociology, or like me, history. The second level is a master's degree in social work. We like to think about this as the practice degree. There are over 200 graduate schools of social work in the United States that produce MSWs. And then finally, at the PhD level, there are about 70 PhD programs in social work across the country. At the BSW level, or BA level, workers engage primarily in direct practice. They might be a case manager in a child welfare agency or a probation officer, or they might work in a United Way as a program evaluator. At the MSW level, they engage in advanced practice. They often have leadership positions providing clinical supervision or organizational supervision. It's at this level, I think, where evidence-based practice probably comes into play. We expect our MSW level social workers to be able to identify discrete intervention strategies, programs, or treatment plans, and match those to the needs of the people with whom they're working. And the PhD is largely a research degree. It focuses on assessing the effectiveness of existing programs, and I think more creatively perhaps designing new programs to produce better outcomes than current programs. Evidence-based practice in social work is practice that's based on the integration of the best currently available evidence with clinical expertise and the values and preferences of service recipients. So it's a basic SACIT definition, and there are challenges at each level, identifying what the best evidence might be, finding the current evidence, assessing it, and then integrating it with one's practice experience, and then ensuring that it's always tempered by the conditions that confront the people with whom we're working: culture, gender, language, religion, and the kinds of problems that are presented. And usually the problems are multiplex, and that presents another set of issues, because usually programs and interventions are keyed by single health or social problems. For example, child maltreatment, but it's rare that we have simple child maltreatment. Indeed, if we just take child maltreatment, you might have neglect, educational neglect, medical neglect. You might have a family where there's drug abuse. You also might have a family where there's serious mental illness, educational disengagement, and perhaps one parent incarcerated. So problems are usually more complicated than research. There are 7 steps in evidence-based practice in social work. The first is formulating a clear question based on a social or health problem. And I say to my students, you have to start by defining the problem. What is the problem? And if it's not a simple problem, then make a list of the problems. Second is searching the literature. Third is appraising the evidence found in that literature. Fourth, selecting from the literature the best evidence for an intervention decision. Fifth, linking evidence with practice experience, knowledge, and the values and preferences of service recipients. Sixth, implementing findings in practice and programs. And seventh, evaluating results. At every one of these steps, we confront huge challenges. So the role of the practitioner is to access and read research and research syntheses, to be able to critically appraise research and research syntheses, to give meaning to it, to contextualize it, to condition the research findings on the complexity of practice. So, for example, we might have an intervention in the field of juvenile justice that says parenting training operates to reduce aggressive behavior in childhood. And so when we have a child who's 8, 9, 10, 11, or 12 who is non-compliant, hypervigilant, perhaps out of control, that parenting training would be a good strategy. But it may be that it's not just that the child has aggressive behavior, but it may also be that the child is embedded in a network of other kids who are the same. And so homophily begins to work in the sense that a child is exposed to role models of delinquent or deviant behavior in the peer group, and a parenting intervention may be one of those things that's indicated, but it may be insufficient because an intervention also needs to address the social networks in which a child is embedded. So conditioning research findings on a person's understanding of the problem is crucial. Also involving the consumer or the service recipient. This may be a little easier, for social work does have a tradition of involving service recipients. And as a profession, I think perhaps more so than some other professions, we have been willing to be on the street. We've been willing to go into people's homes and to try to understand what it's like to live in that place, and then to tailor our interventions to that particular setting. And then the practitioner also has to develop and implement an evidence-based strategy. And although it would be great to simply be able to go to the Campbell collaboration or the Cochrane materials or to a few other sources and read research syntheses, after you've read the research syntheses, as a practitioner, you still have no idea how to do the intervention. Because understanding the research doesn't mean that you have the skill to do the intervention. So we confront a challenge that is not just, in a sense, figuring out how to make this information available to hundreds of thousands of practitioners who operate with differing degrees of education, but also, even after the information is available, we can have no confidence that a person can competently implement an evidence-based practice strategy. The role of the researcher is to produce research that's central to practice. I've been controversial in social work because I've been so persistent in this theme. It's my view that too many of our PhDs are engaged in survey research, studying what happens in agencies or describing problems on the street. And I think we need to move much more forcefully to the position of creative science, where we create interventions and test them experimentally. But researchers also have another challenge. And frankly, I'm not so sure whether just the researchers alone can do this, because the people who know a lot of statistics sometimes aren't able to speak English very well. Have you noticed this? Is this true? I mean, it's like there's an inverse relationship between the more statistics you've had, the less able you are to communicate. And I'm just kidding. But some of you I know have had a lot of stat. I have too. But we do have this challenge of taking our research findings, which tend to be more quantitative, and then distilling from those findings guidelines that our practitioners can read, distilling from the research findings treatment manuals, if it wasn't part of the original research in the first place, and creating other practice resources that allow people to implement an evidence-based strategy. Nurses are really good at this. Have you seen some of the things that nursing has developed? I see a lot of heads nodding. Yeah. I love the pocket guides and the little notes and things that nurses have developed. In social work, we are not anywhere close to that. So, the role of the practitioner is to not to do research. Until about 10 years ago, we had this notion of the clinical scientist or the empirically based practitioner, where we expected, at least our MSW practitioners, to go out and to deliver an intervention, to collect data, determine whether it worked or not, and then to write a journal article on it. That was really naive, and it didn't work very well. I think we are now, as a profession, in a place that's much more compatible with practice, but we still are producing MSWs who probably don't have adequate skills to read and digest and particularly give meaning to the research and research syntheses. And we don't have the literatures yet that will allow them to take an evidence-based practice strategy and apply it or tailor it to practice. So there are two sources of evidence. I guess I've been referring mostly to the nomothetic literature of controlled studies and to some degree uncontrolled studies, control group studies. I think that your research and statistics training is about the same as ours. You take research design classes, you have stat, things like that. If I'm talking about things that are that you don't know, just sort of raise your hand and say, explain that, okay? Because I want us to have a good dialogue about social work and information and library sciences. So control group studies, not the sort of thing where people are randomly assigned to receive an intervention or nothing. That would be unethical. But the sort of thing where people might be randomly assigned to a new intervention that builds on an existing intervention and then compared to routine services. So the idea is always to provide an intervention to people in need and then to try to build on top of the existing services to improve the effectiveness of services. And this can be tested. It's probably best tested in control group studies, but there are some uncontrolled studies that attempt to use sort of fancy schmancy statistical modeling, and occasionally that can be impressive. We also have relevant explanatory research, particularly coming from child developmentalists, principally in psychology, but also in sociology and public health. We're beginning to benefit from the 20 years of funding from the National Institutes of Health of a number of longitudinal studies of children and families. And they're enormously illuminating about the developmental trajectories that lead to poor life course outcomes. So this is a rich source of information for, and I'm going to give you an example in a couple minutes, for the design of innovative social and health services. Cross-sectional surveys are a little less so, but sometimes they can be sort of a starting point for a good qualitative analysis or maybe a longitudinal project to understand all the factors, all the complexities that yield poor outcomes in adolescence or in adulthood. There also are a number of very good qualitative resources in sociology and anthropology, and we've kind of yet to figure out how to make use of those. But there are particularly good books on urban ethnography that kind of uncover street codes and how children are influenced by codes of the street to be more aggressive in certain kinds of circumstances. These, I think, can inform social work practice. And finally, we have something called single case studies. in which multiple interventions may be tried with a single case or a group of cases over time, and outcomes monitored, sort of in the way of a time series design, except not using as many cases or data points. So all that can be thought of, I guess, as nomothetic or perhaps more science-based information. And then we have we have ideographic information, which is case-based. This builds on the experiences of people who are receiving services, but also it includes the experiences of the practitioner. So in evidence-based practice and social work, we ask the practitioner to draw on that practice experience. We don't say it's irrelevant, but we say your knowledge and experience in working with a particular kind of family or child or adult should be brought to bear in making practice decisions. And we also have clinical supervision, which is rarely mentioned when we talk about evidence-based practice. But I think the average MSW and BA level social worker is most influenced by clinical supervision and not by any reading that he or she does. So perhaps one of the strategies to think about together is how we begin to identify who the clinical supervisors are and how we access them and expose them to new knowledge. So there's also controversy about what is the best evidence. Is it only RCTs, randomized controlled trials, and reviews of these RCTs? Frankly, in social work, these are pretty scarce. So we tend to draw on literature, not just in social work, but in psychology and sociology and medicine, and public health as well. RCTs also are of dubious generalizability. The social workers tend to work kind of at the edges of society. We work with people from all different kinds of backgrounds. We have social workers on tribal lands. We have social workers working with Lao families in Charlotte. We have social workers working with African American kids in downtown Durham, not so far from here, in urban areas in New York, in Miami with Latino families. They work with every kind of person that one can think of in terms of race, ethnicity, sexual orientation, gender. And the RCTs rarely are diverse enough to fully inform social work practice. Moreover, RCTs produce findings by mean scores. I mean, it's ultimately, even in the face of fancy schmancy statistics, it winds up being a mean score divided by a standard deviation, right? I mean, you adjust the standard deviation for multiple levels if you're using hierarchical linear modeling, or you may have a latent model where you have multiple indicators, but it really comes down to mean scores and standard deviations. And that mean score may or may not apply to the particular case that, if you were the social worker, you are working on. So it leads us to ask the question, should we value less well-controlled studies? Should we keep our focus, as in medicine, just on randomized controlled trials, or should we draw on knowledge, even though it may be less scientifically rigorous, that exists in less well-controlled studies, and especially longitudinal research? I noticed one of the poster papers out there is using this approach. It's kind of a common hierarchy of knowledge that we see in medicine, often thinking that kind of at the pinnacle of the triangle, here we have the greatest rigor with systematic reviews and meta-analyses and randomized controlled double-blind studies. It's almost impossible to do a double-blind study in social work. People receiving service know they're getting a certain kind of service, and the people delivering service know whether they're in an intervention group or a routine services group. So this type of paradigm, although it may work in medicine, really leaves us with probably less than 20 studies to draw on. So we have longitudinal studies, cohort studies that we can draw on. We have case control studies. And then there's a whole set of studies that range from case reports to empirically based, good science-supported theory. And one of the big debates in my profession is how much to rely on this stuff down here. So what if there's no evidence? Can we rely on anecdotal case reports? Can we rely on correlational studies? Can we rely on empirically supported theory? Let me give you an example from my own research. After Columbine, the National Institutes of Health became very concerned about school violence. There was no single place where research was being done on school violence at the National Institutes of Health. So they created a task force on school violence, and they released requests for proposals. With my colleagues, I applied, and I was funded to develop a particular kind of intervention strategy for elementary school children. We had identified cascades of risk that showed how risk factors in early childhood lead to risk factors in middle childhood and lead to risk factors in adolescence. And we argued that we wanted to try to disrupt those risk trajectories. So the intervention, which was one of many that was funded, there were about a dozen projects across the country that were funded by this NIH task force. Our intervention was to develop social problem-solving skills training programs for elementary school children. We wanted to reduce peer rejection, which in the literature winds up being probably the second most important risk factor for delinquency in school violence, some sorts of school violence, not all sorts, and alienation from peers. So we wanted to try to, working with second, third, and fourth graders, we wanted to try to reduce peer rejection and reduce both social and physical aggression. The more popular manifestation of social aggression is bullying, but there are more nuanced definitions of social aggression. It involves excluding others from your peer group, starting false rumors about them to be mean. Frankly, it's the sort of thing that those of you who are not male might be really good at. In fact, our data suggests that the boys are kind of clueless about social aggression, but the girls get really, really good at it, particularly in middle school. And it's not entirely clear when the boys kind of get clued into all of this. It certainly is beyond our data, and some of my staff think that it may be like about age 34 or so when the boys become relationally sensitive. But girls have high relational sensitivity, and that relational sensitivity translates to a different form of aggressive behavior in childhood. And so we wanted to create a gender-specific intervention that would deal with the kind of aggressive behavior that we thought may put some girls at risk. And we also wanted to deal with the more traditional aggressive behavior, physical or overt aggression, that we also knew puts boys at risk for delinquency and drug use and other sorts of things. So the NIH liked our ideas, and there was no compelling research at this point in time. So we had to make use of empirically based theory, and I think I have a slide. Yeah, so here's one of the images that we used in this proposal. So on the left are risk factors that occur during the neonatal period and postnatal period. They involve maternal smoking or substance abuse, poor nutrition, poor maternal nutrition, poor health care, and poverty. So these are a set of research-supported developmental predictors of poor life course outcomes. I mean, it is true that there is literature that suggests that maternal smoking, for example, during the neonatal period is weakly correlated with delinquency of children some 15 to 16 years later. So this is the type of research that's beginning to come out of these really marvelous longitudinal studies that have been funded by NIH. So then we said, okay, well, what happens next if there's no intervention to disrupt this transition in years sort of 1 to 5? What happens? And it turns out that the risk factors then sort of blossom, and you can classify them as risk factors that are in the parent of the home, risk factors that are a little more individually focused on the child, and then risk factors that are related to the environment in which many kids are embedded outside the home, the preschool, or being with another caretaker. So in the home, risk factors include having a parent who's distracted by work or because of drugs or because she or he is just generally distracted, low attachment between child and parent, use of harsh physical discipline, and withdrawal of the parent from the child. It's not clear that this would be caused necessarily by the parent, because there's also strong evidence that suggests that some children just pop out and the first thing they say is no. And there's no way I'm going to do whatever you want. And so temperament begins to influence parenting and the parent-child attachment. So the causal connections are uncertain at this point in time. So in these risk factor models, we can posit risk markers for poor developmental outcome, but we need to be careful to say that it may not be parenting behavior is the cause of these problems. In fact, my sense is it's probably the other way around, and that is that having a very difficult temperamental child affects parenting behavior. It can increase distance, it makes parenting much more challenging, and so there are a whole host of kind of connections here that the risk factor approach has a tendency to ignore. But that's one of the nice things about this cascades approach, because it doesn't necessarily mean that you wouldn't do a parenting intervention, but it suggests that you also might have to do an intervention with the child to try to control temperamental behavior. So then there's a whole set of characteristics, risk factors, at the preschool or caretaker level that include poor supervision of a child, low engagement or perhaps even rejection, low family involvement with the preschool, and inconsistent discipline. So again, lacking intervention. As children move to age 6 to 12, we see a kind of flowering of the risk factors as they're becoming a little more specific. In the home, you find a kind of parenting style that involves increasing nagging and nattering. Oh, this is good. Okay. I know a lot of you have high GRE scores, right? So what's the difference between nagging and nattering? Come on. I know I'm talking to a really smart group of people.
Is it tone?
Yeah, it's partially tone. Yeah. Yep. Yeah. Content. Yeah. Okay, so keep going. Come on. You got to go. Come on. You got to tell me this.
Is nagging specific to one subject and nattering is just general complaint?
Yeah, I'm kind of nagging you right now, aren't I? Am I being pretty annoying? Yeah, I think so. So that would be nagging. And nattering is sort of inconsequential babble. So it's like, okay, it's time for dinner. Come on, let's have dinner. Are you watching TV again? I don't like that show that you watch TV. Oh my gosh, the soup is boiling over and I don't have any milk. What in the world is going? Would you get off that TV program? Get over here and sit down. I don't want you playing video games tonight either. So that's that's nagging. So in a lot of homes, that's nattering. That's it. Yeah. And nagging is more focused, okay? Focused on a particular thing, like trying to elicit from you definitions of nagging and nattering. Also, a set of risk factors begin to emerge around parenting, a little more specific. There tend to be fewer rewards in households where children are likely to get in trouble. Harsh discipline becomes harsher. There's greater distancing between parents and children. Low attachment, low supervision. Sometimes, in fact, children start to wander at this point in time. Parents don't know where they are after school. And there's usually poor home-school connections. In children following this developmental trajectory, we usually see increasing aggressive behavior, and there's a specific sort of micro-social risk process that we targeted, and I'm not going to go through that now, but there's a kind of learning theory-based approach that actually parents engage in behaviors that reinforce aggressive behavior. And they do it without their knowledge, and they don't really want to, but it happens in households like this. Children begin to have hostile attributions, so do parents. So that means that they perceive the other person as being hostile or not liking them. And that may generalize to others in the environment. So a child that comes from a home like this may go to school and may see a social worker or a librarian or a teacher and immediately assume that she is out to get him. And that means that there may be deficits in the way the child processes social information and draws inferences from it. This all adds up to poor social problem solving, being a little more instrumental. Sometimes we see children from households like this, and their behavior is all about controlling their environment. So on the playground, if there's a couple basketballs, their instrumentalism will lead them to try to control those basketballs at the expense of relationships with their peers. So they're not very good at sharing, not very good at bargaining. And it begins to spill over into academics, usually first language arts and then math. And by the first grade, and certainly by the third grade, children like this begin to be rejected by their peers. There are a whole lot of things that happen in schools. Teachers tend not to like children like this. They give lower feedback, and so you have lower academic achievement, and there's low social support. So this is just what, there are other ways to look at trajectories related to aggressive behavior and school violence. This is just one, and it certainly doesn't incorporate trajectories that involve gangs. There is an angle related to this in terms of poverty. There are also angles related to this in terms of cognition. So I'm just presenting a fairly simple risk approach to understanding poor child outcomes. But this is what we presented to NIH, and we argued that we were going to try to develop an intervention that would disrupt the cycle here or here by dealing with just one aspect. So dealing with the aggressive behavior, the hostile attribution, the poor problem solving, and the instrumentalism in terms of social goals. We went to the literature. Actually, what happened is I went to the library. I did. It was summer. I went to the library and I sat there and I was going, I'm really tired with what I've been doing lately. I had been evaluating programs in child welfare, and I had just seen so many families and so many kids, and I thought there's got to be something new. This was 1994. So I decided I was going to read all the latest journals in psychology and social work, just the latest ones. So I went to the current journal area. Do you all have current journal areas where you work? So I went there and I sat down. It was the summertime. And I started going through journals, and I came across one article in a journal called Psychological Bulletin. Very good psych journal. And it was all about a new sort of cognitive way to think about social problem solving. And I read that, and I said, I think this could be the start of an intervention. If I were to take this idea, which really was just in developmental psychology at that point in time. There were no intervention studies. So at this point in time, there was a kind of common way to approach social problem solving with children, It was to ask them to state the problem. You probably do this with your kids. I do it with mine. So ask them to state what the problem is. Okay, what's going on? Who did what? To set some goals. What do you want to have happen? To generate some potential solutions. Okay, so how are you going to get there? And to select, to evaluate those in terms of whether they'd be effective, to select one and enact it. Well, and then assess the outcomes. We became convinced that this was a wrong approach. It was used in all elementary schools across the country, basically. It had been used for 15 years. It was based on a model developed by people named Drusilla and Goldfried in the mid-60s. When we read that article, we concluded that there were cognitive states that precluded any of this happening in aggressive children. And that's why social problem solving had such low effect sizes, why it was widely regarded as ineffective. The first thing we said that happens is children encode social cues in their environment. They look at you and they look at your face, they look at your eyes, they look at what you're wearing, they look at your posture, they look around you, and they decide about you, whether you're friendly or hostile. And it turns out that in these studies, children who are aggressive constantly encode, guess what? The most aggressive cues. And they ignore most of the other cues. So if you're the teacher and this child comes to you in the second grade and you're sitting there maybe with your hands like this or like this or like this talking to the child may assume you don't care. The child may falsely assume, moreover, that you're out to get him or get her. This was shown at this point in time in probably 6 or 7 developmental studies. Children with aggressive behavior had encoding deficits. The second piece of it, and I've already alluded to it, is they also had interpretation deficits. They would interpret that you, if you're the librarian or the teacher or the social worker or the psychologist, they would interpret that your intent was hostile, even when it wasn't. So the whole problem-solving process then was conditioned on these encoding and interpretation skills. Also, of course, it's conditioned on a child's arousal, because rapid arousal, getting angry quickly, can short-circuit this kind of cognitive process. And it's based on a child's prior social knowledge and life experiences. So, a kid who comes from an urban area and he has to walk by crack houses every day to get to school, or walk by gangs, may legitimately assume that people could be out to get him. A kid who comes from a household where she's been maltreated or has experienced a lot of domestic violence may legitimately assume that adults can be dangerous. So these encoding and interpretation skills may arise from survival strategies that help a child be resilient in the face of great family or community adversity. But when a child goes to school, those same skills become dysfunctional, because it begins to impair the child's ability to sustain relationships with teachers and with peers. And it creates, for an aggressive child, another risk factor called peer isolation. And as children are increasingly isolated from peers, they're increasingly beyond the normative controls of peers, which means that their aggressive behavior increases. So we took these ideas and we put them together into a skills training intervention called Making Choices. To make a very long story short, we've engaged now in 10 to 15 years of research. I guess there's a lot more than 8 or 9 papers. We probably have 15 or 20 papers overall. We've done 3 control group trials, currently involved in a very large trial where we've randomized 14 North Carolina schools. And I've just received a grant from the People's Republic of China to try to implement the program in China. Most of our findings suggest that we are successful in reducing overt aggressive behavior, that we reduce social aggressive behavior. In fact, our biggest treatment effect is on social aggression, that we increase social competence, and we increase cognitive concentration, which is the ability to stay in your seat, not disturb the work of others, stay focused on task. So it's kind of a, what would you call it, maybe a precursor to academic achievement. So this program by itself probably doesn't affect academic achievement, but it may affect some achievement-related skills. So how good is this? How do we, in the context of evidence-based practice, how do we evaluate this program that has had funding from NIH and from the U.S. Department of Education and a variety of foundations? Well, we can use a kind of common category scheme where we say the highest order of goodness would be evidence from at least one properly randomized controlled trial. A second level would be evidence from well-designed controlled trials but without random assignment. So we probably fall somewhere around category 1 at this point in time. And category 2 would have a kind of second level evidence from well-designed cohort or case control analytic studies, preferably from more than one center or research group. So we definitely did that in developing this intervention by drawing on a variety of cohort studies. Evidence 2 sub 3 would be evidence from multiple time series with or without intervention or dramatic results from uncontrolled experiments, such as the results of the introduction of penicillin treatment in the 1940s. And category 3, opinions of respected authorities based on clinical experience, descriptive studies, case reports, and reports of expert committees. I'm very skeptical of category 3 because social work has had an authority orientation, and one of my themes has been to move more towards a science-based process of decision making. So we have making choices, probably category 1. And from this, we've begun to define a kind of new intervention process, which we're calling intervention research building knowledge for practice. It involves drawing on literature and epidemiology, which is incidence and prevalence studies, explanatory knowledge, meaning those cohort studies, intervention knowledge, meaning studies of whether interventions work relative to randomized control groups or comparison groups, local knowledge. Would making choices work out in Navajo tribal lands? I don't know. I spent years out in Utah, maybe a dozen years, and I think the first thing I do is I go find a medicine man or a curandera, and I'd say, this is the program, do you think it'll work here? So local knowledge means knowing the local community, the specific culture, language, and religious parameters that might affect an evidence-based program, and practice experience. So these go into program design. This leads to an efficacy test, which is a small controlled trial, usually where the researcher is deeply involved in the development of the intervention and the delivery of the intervention. So in most of my studies so far, I or the people who work for me have been either providing the intervention or supervising the intervention. The next step is a little scary because it involves allowing the intervention to be tested in practice without the control of the researcher and relying on the practice community then to take a treatment manual and implement it with fidelity. This is my current, I might say, this is my current Department of Education trial, and we have, across the 14 schools, we have enormous variation in terms of the faithfulness of the delivery of the intervention. So I think, as a number of other researchers across the country are discovering, there's a huge challenge in taking evidence-based information and implementing it faithfully. And then finally there's dissemination, and at any point in time we can observe a negative finding and it can move us back another step and cause us to do to address some sort of new research study. So efficacy trials are single case studies, usually small group studies, and they can happen in a single agency or a single school in our case, and then they get expanded. The President's New Freedom Commission, about 2 years ago, reflected on this notion of intervention research. It was a panel of more than 20 scholars from a variety of different professions, and they attempted to define a sciences to services cycle. Have you seen this? I thought this might be of interest to you because I think it raises all the issues that I've been talking about. We start with identification of research gaps or needs. So in my case, using the making choices example, I observed that it might be possible to disrupt risk trajectories by addressing hostile attribution, early aggressive behavior, poor social problem-solving skills among young children. A research agenda might be set. It was fortunate for me that the NIH had decided to fund school violence prevention programs just at the point at which we had a treatment manual developed. That took about 3 years for us to do that. And we had begun to conduct research. So you have a phase of intervention research that involves research and development. It usually involves collaboration with schools or other agencies. If the research is successful, then the next step is to develop support among state and community infrastructures. In this case, this would mean that a public school system might choose to adopt the Making Choices program. Or it might be listed, as it currently is with the State Department of Public Instruction, as a social and character development program that has empirical support, and it's available to all the school districts throughout North Carolina. But it also means beginning to understand performance, beginning to develop performance and monitoring systems to assess the impact of fidelity and the adaptation of outcomes. So it's not just the identification of an evidence-based strategy, but it's the development of systems to support it. And if these are successful, growing commitment at the state level then leads to a whole set of activities, and we have very few programs in the social work sector where we have registries of effective programs and registries of practitioners who are trained in those programs. Maybe we have them with a program called Assertive Community Treatment, and maybe we have them with a program called Multi-Systemic Family Intervention. But those two programs, I think, are about it. The research base is far broader, but the development of certification and registry programs is at a very primitive stage. So this is the sciences to services cycle that starts with intervention research and leads to developing infrastructure support related to fidelity, and then to registry programs for individual practitioners. So the steps are to understand the incidence and prevalence of a problem, identify change-sensitive explanatory factors, design a prototype intervention strategy, pilot test under control conditions, revise on the basis of the pilot test, test under real-world conditions, that's the effectiveness trial, and then take it to scale and disseminate. There are lots of implications of this for social work. First, there's a huge challenge for professional organizations and universities. We simply have to increase the volume of intervention research. We have to create a range of practice resources that will synthesize and translate research. And this means creating new means for practitioners to access practice resources. It means for the researchers they have to write practice guidelines and treatment manuals, but it means, I think for you, and probably for me, creating means for practitioners to access this information. There are a bunch of research challenges as well. Of course, we need to do more randomized designs with treatment manuals. We need to ensure sampling of at-risk subjects, which we don't currently do. We need to develop culturally sensitive measures and interventions, also gender-sensitive measures and interventions. And we need to ask, when do we take it to scale? Is Making Choices ready for China? Why would it be implemented in China more broadly than in the United States? But that's going to be the case. When do you take an intervention to scale? And right now I think it's too happenstantial. We have a field called translational research. And so I've labeled this slide, I think it's the last slide, as translational challenges. On the science side, we need more knowledge about dissemination and implementation processes. This includes understanding the organizational contingencies that affect the adoption of innovations, and it includes understanding the full translational process that results in adherence to an evidence-based strategy and full fidelity. On the practice side, it means getting knowledge of the best currently available interventions to practitioners. It means training to try to create an organizational willingness to innovate and learn and experiment. Simply providing that knowledge to the practitioners will be insufficient because they're embedded in organizational cultures that will either promote innovation or promote routine practice. And I'm afraid the force of inertia is such that many organizations will simply promote routine practice and not risk experimentation. Next, we have to figure out how to train practitioners to implement these interventions. It will not be enough to simply provide practitioners with treatment manuals and practice guidelines. There has to be a way for them to skill up. They can't develop skills simply from reading the research or reading about what works. So this involves extensive, I think, registration and certification programs in evidence-based practices, plus accessing the clinical supervisors so that we can provide ways for sustained skill development. Because we all know that skills don't develop through one speech, one burst of training, but they develop over time, sustained by feedback and successive approximation. So those are the challenges that we confront in social work in terms of evidence-based practice, and we desperately need your help. Thank you very much.
We have time for a few questions. I actually...
Sure. Do you want to moderate, or should I?
No, please.
Okay. Yes.
Okay. You started out this research with this theory, and I mean, this is really interesting. In our field, we're a little short in theories. There are a few uniquely LIS theories, but we don't use a theoretical base, I don't think, very much in the design and carrying out. And I'm just wondering if you could comment on your use of that in social work. Does it have a lot of credibility among your practitioners? Do you have the same old, oh, don't give us the theory, we want the practice kind of thing in your master's program, that kind of thing?
So the question is, in information and library sciences, we don't use a lot of theory. If people are more interested in learning the tools of the trade relatively quickly. Does that exist in social work? Yes, it does. Our master's students are desperate to get more tricks and gimmicks and gadgets in their tool bag, but what we say, and so far we've stuck to it, is that what we can train people in 1 or 2 years of master's work will be obsolete within 5 years, just like most books are, frankly. And so students have to understand empirically based theory and also have access to ongoing information in order to keep their practice alive and current and creative. Yes?
You mentioned a couple of times around the actual state of the knowledge base, what sort of evidence exists. And also you mentioned the issue about the gap between what we need to know and what's already known. And I just wondered whether or not you've had any sort of debates within social work around how you present uncertainty. In healthcare at the moment, working on a program to systematically identify uncertainties on the basis that it's important as important to know what we don't know as to what we do know, particularly to influence research funders. But the interesting side effect is that when you're coming to present knowledge to people making a choice, if you're trying to work with your clients and whatever your sort of customers to help them make a choice, that you have a duty to actually be explicit about what we don't know, which is a very hard thing to do professionally. Has that sort of come up in your work in social work?
So the question is, there are perhaps a few certainties in social work and many uncertainties, and do we train, or has it arisen that we ask our practitioners to explain those uncertainties in the context of what might be an evidence-based strategy? And the answer is the first time that I've been aware of that occurring at the level of a national conference was last November. We had our first national conference on evidence-based practice, and the issue of uncertainty was raised. It's almost impossible for me to think that could be happening at the practice level right now, because so few practitioners are aware of the certainties that for them to sit down with a family and say, okay, we have 3 choices around parenting training, but frankly, parenting training is only it only has an odds of being successful about half of the time, and we also have an intervention for children which is going to be successful about half of the time. What would you like to do? And if they're talking to a family where there's drug abuse and a lot of complications, it may be that the family, or if it happens to be an involuntary family, it may be that the family would go, well, given the fact that the knowledge base is so weak, we elect to do nothing, thank you, goodbye. Or they might say we want to do both. I just don't think, well, I know that level of practice doesn't exist in social work yet. Hopefully it will at some point. I think it's beginning to happen in medicine.
Only just.
Yeah. Yes?
I just wanted to comment that I read Stephen Covey's newest book recently, and one quote that stuck out from that was, never ascribe to anybody else motives that are meaner than your own. That came to mind when you were talking about how children make assumptions about the intent of the provider. Secondly, I'm wondering if you have any comments about social intelligence. Does that concept come up? And
the constructs of social intelligence and emotional intelligence are widely known in the popular literature. In the social science literature, including the social work research literature, it gets subsumed under the literature on, called social development, where we look at factors that promote social development. And so the idea of social problem-solving skills and social competence is really sort of folded together with this notion of social intelligence and emotional intelligence.
because reading the book, the initial book that proposed that idea, to me, I was shocked because in the popular understanding, it's way different than the original one. The original understanding was more that there's almost a biological basis for those kind of things. So I would think that you would have to really think about nature, nurture ideas.
Yeah, there's very interesting research on the intersection of genetic liability and aggressive behavior, and for that matter, shy behavior as well. And I think over the next 5 to 10 years, we'll be thinking mostly in terms of these interaction models where the environment triggers genetic liability in some way. So that's going to put social workers right at the forefront of it, because social workers work with poverty and discrimination. They're out on the street. Those are the kind of environments that tend to unleash, for better or worse, genetic liability.
One last thing.
Yeah.
The whole issue these days about mental health medications causing suicidality in children and things like that, has that come to your attention?
I don't know enough about that to say anything about it. Okay, way over here.
Thank you. I was rather taken by your model of a trajectory and the way that certain things happening at earlier stages can then lead on, and there can be this. Is that something exclusively developed within your field? Because I can see the application of it, say, to how we teach information skills to primary school children might have an impact on how they learn as undergraduates if we were to take that sort of trajectory approach. I wonder, is that from outside your profession, or is that something that is an approach that sort of has been derived from within your profession?
The risk factor approach arose initially in public health and psychology, and social work has been a part of that. So it's not just social work, but I think that people in public health, psychology, social work, and sociology all are beginning to speak this language of developmental trajectories and cascades of risk. It takes us out of the baggage of causal modeling and structural equation modeling, where everything has to be so precise, and it allows us to list a set of risk factors, some of which may be malleable through intervention. Okay. I guess we don't have time, but I'm going to stay up here. I'd be delighted to talk to you one-on-one. So thank you very much. I greatly enjoyed talking with you. Thanks.